So welcome everyone, and welcome to the latest in the series of EAAA's Lunch and Learn series. My name is Sue Leach and I'm a board member at EAAA, and it's my great pleasure to welcome you to this session today. But firstly, I'd like to let you know that I'm coming to you from beautiful Lutruwita in Tasmania. And I would like to take this opportunity to acknowledge elders and their deep connection to land, sea and water, the river countries across this beautiful country, and pay my deepest respects to elders past, present, and those emerging leaders as well. So you may already know a little bit about EAAA. Essentially, we have three pillars. We are here to put a national voice to end elder abuse, and we do that in a number of ways. So there are activities of EAAA, such as the Lunch and Learn series. We're also responsible for the very valuable resource Compass, and if you haven't checked that out, I would like to encourage you to go and have a look at the Compass website. There's some very great resources there as well. And we're also responsible for running the National Elder Abuse Conference, which is a highlight in this space where we can come together and try and tackle this serious issue. But today we're here to hear from Justice Connect, and this session will provide an overview about how Justice Connect's senior law program delivers legal services to older people who are experiencing or at risk of elder abuse through the Health Justice Partnership model, and the benefits of this integrated service model in responding to elder abuse. And today we have two speakers from Justice Connect. So we have Yvonne Lipianin, who's a lawyer at Justice Connect, and Yvonne has worked in community legal sector for 17 years now, initially at Victoria Legal Aid, where she practiced criminal and civil law. She joined Justice Connect in 2015 and now manages Seniors Law, which is a program operating in Sydney and Melbourne, and it provides legal help to older people experiencing or at risk of abuse through partnership with health services. We also have with us today Carolyn Odgers, who also works for Justice Connect as a lawyer in the Seniors Law program. She works in a health justice partnership with the War Memorial Hospital, which is funded by the Commonwealth Attorney General's Department. Carolyn has worked as a lawyer in the community legal sector for 15 years and also has experience providing advice in the areas of social security and tenancy law, and has a thorough knowledge of the sector, allowing her to make good referrals for free legal assistance. So I would now like to hand over to Yvonne firstly, who's going to be doing a presentation, and followed by Carolyn. Thank you.
Thanks very much, Sue. So I have some slides, which I'm going to have a go at sharing right now. So let me know if you can see them. How's that? Is that working? Excellent. So thanks so much, everyone, for coming along today to this session about the work of elder abuse, about the work of Justice Connect in responding to elder abuse. I'd also like to acknowledge the traditional owners of the lands on which we're all coming from. For me, that's the lands of the Gadigal people of the Eora Nation, here at my home office in Kingsford in Sydney. So yes, I'm Yvonne. I'm the manager of Seniors Law at Justice Connect, and as Sue mentioned, I'm joined by my colleague Carolyn, who's a lawyer working with War Memorial Hospital in Sydney, and we'll hear a little bit more from Carolyn shortly. So today what we're going to do is provide you with an overview of Seniors Law's work, focusing initially on our core services, which we provide through the Health Justice Partnership model, as you just heard from Sue. I'm going to talk briefly about what a health justice partnership is, with apologies to people out there who already know about health justice partnerships. We are going to look at it in a bit of depth. Why we chose it as a service delivery model to respond to elder abuse, and an overview of the different HJPs that we've established. And then I'll hand over to Carolyn to talk in some depth about how the model operates at War Memorial Hospital and what it's like being a lawyer in a health setting. After we've heard from Carolyn, we'll come back to me, and I'm then going to talk about some of the interesting and innovative project work that Seniors Law has been undertaking over the last couple of years. So quickly, who are we? You just heard a bit. Justice Connect is a community legal centre operating in New South Wales and Victoria, and Seniors Law is one of Justice Connect's programs. It started in Melbourne around 12 years ago, and the focus of that program has always been on trying to respond to and prevent elder abuse. And over the years, we've trialled a number of different methods of service delivery in pursuit of that aim. So a lot of different incarnations of outreach clinics with different partners. We had a lawyer on a bus for a while, going around to different aged care facilities. So we did try to be quite creative in our service design. But what we did find in the early years of our program was that we were really struggling to actually reach older people who are experiencing abuse. So we would get referrals for other older people who are experiencing other legal issues associated with aging, but not so much people who are actually experiencing abuse. And I don't need to labour the point here. I think, as we all know very well, there are a lot of reasons why an older person might not seek out help, particularly legal help, whether that's shame, social isolation, fear of the perpetrator, lack of knowledge about services. So it was around 9 years ago that we first trialled the Health Justice Partnership model in Melbourne with CoHealth, which is a community health service in Melbourne's north and western suburbs that we already had a relationship with, as we'd previously run an outreach clinic with them at one of their sites. And since the establishment of that HJP, we've gone on to establish another one in Victoria and 2 in New South Wales. And it's the sole way that we currently deliver our services, as we feel strongly that this is the most successful model that we've trialled to date to reach and connect with older people who are experiencing abuse. So in addition to our HJP with CoHealth, we have established another partnership with St Vincent's Hospital in Melbourne. That was back in 2015. And then in Sydney, we have established one with the St Vincent's Health Network here too. That incorporates both St Vincent's Hospital itself, the acute hospital in central Sydney, and St Joseph's Hospital, which is a subacute hospital out in Sydney's west. That was established in 2017. And then finally, our partnership with War Memorial Hospital, which was established in 2019. And that's another subacute hospital in Sydney's east. So what is a health justice partnership? Essentially, it involves embedding a lawyer into a hospital or other health setting to be co-located on site within the health service to deliver legal help to vulnerable clients who, but for encountering the lawyer there, would probably not have accessed legal help anywhere else. So why do we find it to work? So one of the reasons we found it to be successful is really borne out in the findings of the recent National Elder Abuse Prevalence Study, which I'm sure you're all familiar with. It essentially found that of those older people who do seek help to address abuse they're experiencing, they're much more likely to seek help from a health professional than a lawyer. So whether it's a distrust of lawyers or a lack of knowledge about the availability of free legal services that could assist them, the prevalence study really did confirm our experience of working in this field, which is that many older people who are experiencing abuse will not proactively seek out legal help to address the abuse. So if we do want to be able to deliver legal help to them, we've got to be able to work around that. And this model does help us work around that by ensuring that we're placing ourselves within the services that older people actually use, and we're working closely alongside the professionals that older people do trust and do confide in. Another reason it works, it's about the nature of the partnership with the health services. So our HJPs, in our HJPs, our lawyers are co-located on site within our health partners, usually for 1 or 2 days per week at least. They're really integrated into the health teams and attend meetings, case conferences, social events. Our health partners are really committed to our work, and they've established strong governance arrangements around them to support them. And we're essentially embraced as part of the health team within each partnership. So our HJPs are really highly collaborative. They're very intensive. And the way we work together really allows for the development of strong relationships between our lawyers and health staff. And if you don't remember anything else about what we talk about HJPs today, just remember that it's all about relationships, relationships, relationships. If we contrast this with our previous experience of the outreach clinic model, and I do not want to malign outreach clinics at all, I think in the right context, they can work really beautifully to deliver services. This is just our experience in this particular context. But we found our partnerships were much more transactional. So our partners were happy for us to be there. They were accommodating. They found us a room. They may have done some promotion of the service, but that was kind of the limit of their input. And so we found it much harder in that context to develop relationships with staff within those partner organisations. So that the staff didn't really know about us, who we were, what we did, and how we could help. So consequently, we did get some referrals from them, but they just weren't the referrals that we wanted, the elder abuse referrals. Finally, before I hand over to Carolyn, I just want to emphasise another really important aspect of our HJPs is the capacity building work that we do. And I think this element is particularly crucial given the subject matter, elder abuse. As you would all know, the situation is starting to change, but elder abuse is still an issue that a lot of people don't have confidence in recognising. In many organisations, it's not talked about a lot. There's not a lot of training offered. And so staff wouldn't really know what to look for or what to ask, let alone when to refer a matter to a lawyer. And Carolyn's going to talk more about our capacity building, by which I'm talking about education and secondary consultations, but it's a real focus of our collaboration. So I suppose in summary, I would say that the success of the model is really a combination of that improved capacity and confidence to recognise elder abuse that comes about as a result of our capacity building activities and the strength of that relationship with the lawyer. So on that note, I am going to hand over to Carolyn, if I can stop sharing. Oh, sorry, everyone. How do I do that? Stop share. Okay, over to you, Carolyn.
Okay, all right, thanks, Yvonne. So my name is Carolyn Odgers, and as Yvonne said, I'm a lawyer in a health justice partnership at War Memorial, and that's it's a bit blurry picture of War Memorial Hospital. It's a beautiful hospital in the eastern suburbs of Sydney, but first I would like to acknowledge the traditional custodians of the land on which we are meeting today. For me, it's the Gadigal people of the Eora Nation, like Yvonne. I acknowledge that they have occupied and cared for these lands over countless generations, and I acknowledge all elders past and present. Today, I will be talking to you about the Health Justice Partnership, which is a partnership between War Memorial Hospital, which is the health side of the partnership, and Justice Connect, which is the legal side of the partnership. War Memorial is a specialist aged rehab hospital situated in Waverley in the east of Sydney. There are 32 inpatient beds and a wide array of innovative outpatient programs with fantastic health professionals that work in them. There is also a day centre with centre-based activities. There's low-cost accommodation for country and interstate visitors. There's also Waverley Aged Care Assessment Team, which is on the hospital grounds. So there are many people moving through the hospital in any one week. The partnership in New South Wales are funded by the Commonwealth Attorney General's Department, initially under the elder abuse trials, and we've recently received notice that we will be refunded for another 4 years, which is very good news. Okay, hang on. So co-location. A crucial aspect of the partnership is that I'm co-located on the hospital. I'm on site on Mondays and Wednesdays and alternate Thursdays, and I'm available by phone or email on the days that I'm not there. Having the time and opportunity to develop relationships, as Yvonne said, is really important with staff, means that they are more likely to trust the lawyer and have confidence to refer their patients to me when they're concerned that something is amiss. I have an office which is centrally located in the hospital, which I share with another health professional, I attend case conferences, I give education sessions, and I'm around for those corridor conversations, and hopefully I'm regarded as a member of the team. I think the main reason the partnership works so well at War Memorial is because the executive have really embraced and supported the program, and they are always trying to come up with ways to improve the partnership. One of the latest innovations is a consumer member of the steering committee who can give insight to what might work for patients from his point of view. The key to this success is the crucial collaboration between the lawyer and hospital staff. So as Yvonne said, there's multiple barriers to older people disclosing abuse, but they are still accessing health services. An admission to hospital can present an important window of opportunity for an older person to disclose abuse, because this might be the only time that they're away from the perpetrator. The elder abuse prevalence study found that 66% of people reported abuse to a health professional and only 15% reported to a lawyer. So that's another reason why the partnership works so well. Even when the older person doesn't disclose abuse, the healthcare professional is still in an excellent position to pick up on the warning signs. They may overhear conversations with family members or friends, witness family dynamics, or otherwise just develop a sense that something isn't quite right. In a health justice partnership, when healthcare professionals do identify abuse amongst patients, the lawyer can be brought in very quickly to provide free, urgent legal assistance where appropriate as part of a holistic response to the issue. So my role is that I provide education about the service to monthly orientation sessions. So this means I'm letting nearly every new person starting at War Memorial know about elder abuse and the service available. I also provide ongoing education to staff about elder abuse, so things like effective questioning to identify elder abuse and legal issues associated with elder abuse and capacity, amongst other things. I provide education about future planning and elder abuse to outpatients of the hospital in some of their outpatient programs. And as I said, I attend case conferences for both inpatient and outpatients teams. I provide secondary consultations, which are those corridor conversations or email queries from health professionals who may want to discuss a patient's matter before they refer them. But primarily my role is to provide free legal assistance to eligible patients. There's the nature of the legal issues is that I see executing or cancelling powers of attorney and appointments of enduring guardianship, wills in some circumstances, contract matters, apprehended violence orders, and adult children returning home and refusing to leave is another issue that's come up since COVID. Some of the challenges, navigating information sharing, recording of information, and privacy and confidentiality obligations can be really difficult for the lawyer. Balancing a duty of confidentiality with a desire to be open and to be embraced with part of the healthcare team is tricky. It's confusing for staff to be told on one hand that a lawyer is part of the healthcare team and to encourage communication and openness, but on the other that the lawyer can't share certain information with them. Assessing a client's capacity can sometimes be challenging. We take guidance from health professionals, but ultimately it is our call when making the decision. Staying relevant. I've been at the hospital for over 3 years, and it's important to come up with relevant education sessions to deliver to staff. It's interesting to reflect how the model works in different health settings, acute versus subacute. The acute setting at St Vincent's is very different to the subacute setting that I work in. At War Memorial, I've got the opportunity for inpatients. They're often there for 2 weeks, at least 2 weeks. And so I can go up and see the patients a few times over the course of their stay. You know, if they happen to be asleep or they're doing rehab, I can just go down to my office and come up and visit them later. So it's a really good model, because it's you know, it's not pushing people or making them you know, attend appointment at a certain time. I can fit around them. At St Vincent's, there's more urgency due to a turnover of patients in the acute setting. The reality of working in a hospital and constantly having to deal with sickness and death is a challenge, both professionally and personally. But ultimately, it's an extremely rewarding area to work in, and I really love it. So I am going to give you a case study. It's quite long, but I'll try and move through it quickly. I've chosen this one because it's a really good example of a case where health professionals and lawyers work together to get a really good outcome for the patients. Evelyn's name has been changed, but she has given me permission for her story to be told. And Evelyn's story occurred mostly in the COVID lockdown. So Evelyn's medical background was that she was admitted to hospital following a fall. She had had a weight loss and she wasn't coping at home. And the social worker referred Evelyn to the residential transitional aged care program. So that's a program where people come into people's homes, but she was in hospital initially. Her granddaughter was apparently renovating in her home in Melbourne to accommodate her. And Evelyn was still deciding whether to move to Melbourne. The main reason that she didn't want to leave Sydney was because it was social. She enjoyed going to local clubs and bingo. The granddaughter appeared to have good intentions. However, there was a noticeable breakdown in the relationship between Evelyn and the granddaughter. The granddaughter was becoming increasingly frustrated with Evelyn's repeated questions and started avoiding her calls. There was a history of mental illness in the family as well, which made things complicated. There were complex family dynamics, and Evelyn was vulnerable. She was torn between wanting to stay in Sydney, but she had a soft spot for her granddaughter. So I first met her when she was in the aged care facility in October 2020, and the social worker had referred Evelyn to me for advice regarding a current enduring power of attorney and general advice about the move to Melbourne. So Evelyn had some years before appointed her granddaughter as her attorney, and I'll call the granddaughter Susan. And it was to commence when Evelyn lost capacity, so it wasn't current. Evelyn had not appointed a guardian. Due to indications that she and her granddaughter had a difficult relationship, I spoke to Evelyn about that. And when I first met her, she presented as a very articulate woman who was extremely sure of herself. She said that she was concerned about the move. She wasn't sure if she should go. She said Susan was very bossy. She also complained that Susan was very difficult to contact. But she said that she'd given Susan some money towards the renovation, so she felt committed to go. And I asked Evelyn if she had any formal agreement in place regarding her care from Susan, and she said that she didn't. So I gave Evelyn advice and suggested to her that if she felt unsure about the fact that she had appointed Susan as her attorney, that she could consider appointing someone else. But Evelyn said she didn't have anyone else to appoint, and she just decided to leave it. She didn't want to put a formal agreement in place about the exchange of money. She didn't want to revoke the power of attorney, and she decided to go to Melbourne. I also gave Evelyn some additional advice on the need to inform Centrelink about the change of circumstances and the possible impact on the move on her age pension. But Evelyn decided to treat the move as a bit of a holiday initially, and then inform Centrelink when it became permanent. So the move to Melbourne went really badly from the beginning. The property was not suitable for her. The property had a really steep driveway, which she could not move. She could not manage with her walker. She struggled to get in and out, and she felt trapped. Although Susan had spent money on the renovations, they were not particularly for Evelyn's benefit. She had just updated her bathroom. They argued a lot right from the start, and Susan said to Evelyn that she would have to move her into an aged care facility in Melbourne. Evelyn said Susan was taking her around to doctors trying to get a dementia diagnosis. Evelyn was extremely upset about the suggestion that she moved into an aged care home. She didn't know anyone in Melbourne. She'd left her home and friends in Sydney, and she decided to return to Sydney within a few weeks. It was then that Evelyn became aware that Susan had cleared out and rented out her home in Sydney without her permission, so she did not have a home to return to. Evelyn contacted me for advice, and she organised a flight for herself to Sydney. This was right in the middle of the peak of the Melbourne lockdown. So Evelyn needed to go into 2 weeks quarantine on her arrival in Sydney. She was very worried that she would have to pay the quarantine fee, but she was assured that she would not be charged. So how did we assist her? When she was in quarantine, we assisted Evelyn remotely by phone and advised her to revoke the power of attorney. She agreed to do this, so we assisted her by drafting the revocation and posting it to her along with a letter advising Susan in writing of the revocation. Once she had signed the document, Evelyn posted the document and the accompanying letter to Susan. We also obtained a copy of the lease from Susan. Susan had listed herself and Evelyn as joint owners of the property, which they obviously were not. Evelyn was the sole owner of the property. We advised Evelyn that as Susan was not an owner of the property, the lease that the tenants had signed would not be valid. With Evelyn's permission, I referred her to one of our pro bono law firms to represent her. The pro bono lawyers provided Evelyn with free advice and assistance, and they wrote to her on Evelyn's behalf, giving the tenants 2 weeks' notice to leave the property, which fortunately they complied with. Evelyn was looked after by various fantastic social workers during this period. Firstly, she was referred to us by the social worker at War Memorial, and then community social workers worked with Evelyn and found her accommodation after she left quarantine because she was homeless, and they also provided her with psychological support. She also received further assistance from hospital social workers and various other health professionals through this period because she was in and out of hospital due to a health condition. The hospital social workers were able to receive documents from pro bono lawyers and arrange appointments with them. Within 6 weeks of Evelyn returning to Sydney, the tenants had moved out of the property and Evelyn was back in her own home. And the social workers also assisted her with refurnishing her home because Susan had thrown out all of her furniture. So further legal assistance was that she wanted to change her will. So with her permission, I referred her to another pro bono law firm, and the lawyers at that firm provided her with free advice and assistance to draft a new will. Evelyn contacted me again later because she'd received a notice from Revenue New South Wales stating that she owed them in $3,000 in quarantine fees. As this fee was associated with the elder abuse that she had suffered, I gave her assistance by writing a submission asking Revenue New South Wales to waive the fee, which they initially did not do. I then assisted her by completing a hardship application and gathering letters of support from social workers, bank statements to support the application, and then the fee was waived, which is great news for Evelyn. This matter is a very good example of the effectiveness of the health justice partnership. The social worker identified that Evelyn had a legal issue and referred her to our service, and we provided initial advice. Evelyn was therefore aware that there was a free legal service who could assist her if things went wrong, and when they did go wrong, she sought further advice and assistance. Evelyn has received ongoing advice and assistance from Seniors Law, and it's a really great example of health professionals and lawyers working together to get a really great outcome for a client. Evelyn is extremely happy with the assistance that she received, and she was very relieved to go back into her own home. And that's the end. I don't know if we need questions, but that is my contact details, if you would like, and I'll stop sharing now.
Thanks, Carolyn. That was a great example of the sort of complex issues that can be overlaid in elder abuse, and a good example of how the health justice partnership has been working. Now, if people would like to put any questions forward, there is a panel at the bottom of your screen called Q&A. If you'd like to put your questions in there, that would be really good. And then we can try and address those. We still have plenty of time, so I would encourage people to put those questions forward. I might start off with a question for you, Carolyn, just around the impact of COVID in general on your practice. Do you get a sense that there may have been an increase in elder abuse case presentations because directly of COVID?
Look, I don't think that I could definitively say that. It's very hard to know because obviously during the COVID period, we were restricted. We were out of the hospital for some period and we provided the service remotely. The contact sort of generally between the hospital and myself probably wasn't as strong during that period, although the case numbers didn't go down, but I just had a general sense that it really turned into more of a putting in place enduring powers of attorney and enduring guardianship documents. So I couldn't say that it did increase from my point of view, no.
Yvonne, have you got any thoughts on that? And perhaps subsequently after the lockdowns were sort of lifted a little?
Yeah, look, I think intuitively it makes sense that there has been a higher incidence of elder abuse since the advent of COVID. I mean, it's particularly because of the pressures that COVID put on families and then the kind of implications for older people. I think maybe part of the reason, I mean, as Carolyn said, our service was impacted. So we weren't on site for much of that time. But I also think part of the reason we mightn't have seen a huge jump is because older people themselves, I think, were quite fearful about engaging with any kind of services, including health, during COVID. And I think some of that fear still lingers. So as I said, I do feel that there most likely has been an increase in elder abuse as a result of COVID, but I'm wondering if it's going to take a little bit longer before we start to see it as older people start to emerge again.
Thanks, Yvonne. And just in general, if you could both reflect on the partnership, the particular health and justice partnership. Are you aware of if there are any in more regional areas of the country? And if you're not aware of it, do you think that model would be beneficial in regional areas as well?
Well, I mean, you're okay for me to chat here, Carolyn. Look, I mean, there are a number of health justice partnerships around Australia that other services have established, other legal services and health services that have partnered, and they're not all focused on elder abuse. I know that there are a couple of others that are focused on elder abuse, one, however, in Brisbane and one in Melbourne. So that doesn't respond to your query. Look, I think some of the more generalist HJPs that have been established in different regional areas might potentially incorporate, inquiries around elder abuse, but they're not targeted at trying to draw out elder abuse referrals. Having said that, one of the projects that I'm going to be talking about in a moment is about our Tally Law project with the Murrumbidgee Local Health District in New South Wales, which is not, it's kind of like a hybrid, slightly kind of adapted version of a health justice partnership. So we've been thinking about how it might work in a regional or rural context, and I'll talk about that in a minute.
Great, thanks, Yvonne. We have got another question here regarding enduring powers of attorney, and I know that you're practicing both in Melbourne and Sydney, which is a good example of some of the issues. So they do differ from state to state. Are you aware if there's any move to standardise them nationally?
There is a move to, well, there's certainly a move to establish a national register, and the sticking point seems to be that there are differences within the states as to, you know, the different forms, and so they need to work that out, I guess. And really, you would think that the most sensible thing would be is to adapt or to adopt a Commonwealth legislation in regards to powers of attorney and enduring guardianship. But I guess that's a real minefield of, you know, what happens to the existing ones, and, you know, but yeah, they do differ. They're definitely different between even Queensland, New South Wales and Victoria. They all vary. So yeah, I think it would be a really good idea to make a national document. Would be good.
Thanks, Carolyn. Did you want to elaborate a little bit more, Yvonne, on what you were mentioning before?
About the Tally Law project?
Yes, yes.
Yeah, well, look, I've still got a bit of my presentation to go. So are you happy for me to jump into that now?
Yeah,
and I'll
sure,
start
that would be
talking about
good.
our project
Yeah.
work? Okay, excellent. Just share my screen again. Okay, so you've heard about our health justice partnerships. So in addition to those core legal services, over the last couple of years, we've also undertaken some quite interesting project work in seniors law. And all of these projects have come about because of our strong fertile ground to kind of test new ideas. So the first project I'll talk about is our future planning project, which is one that came about through our HJP with CoHealth. And it's actually, of the projects I'm going to talk about today, it's the only one that is still continuing at the moment. We secured some funding from Perpetual in late 2020 to look at why so few older people put future planning documents in place. And the first thing we did was conducted a literature review, which revealed two reasons. One being that people didn't really know about them or how they worked. And secondly, that there is a real taboo about talking about death, illness and dying. So there's a real reluctance to discuss these topics. So we wanted to interrogate this further, and we ran some workshops with community groups that we were connected with through CoHealth. And we focused on three communities in particular, one being the LGBTIQA+ community, the Vietnamese community, and people aging alone. And we also interviewed some health workers and community members. And what we learned from that process was that it wasn't so much that people were reluctant to talk about death and dying, but that people didn't know how to have those conversations about getting older and future planning. And when we probed further, we discovered that people said that actually, you know, if they could be provided with a safe and comfortable environment, they were really quite keen to have these conversations with their peers, because they acknowledge that this is having conversations of this type are a really important preliminary step that needs to occur before people are ready to think about putting future planning documents in place. So we identified a gap in the existing resources and services, and that was about creating an opportunity to encourage and allow people to sit down and to talk about this stuff together. So to facilitate this, we've created 3 conversation guides for the communities that we were working with, and you can see the front covers of them up there. And these guides were co-designed and tested with the communities that we were working with. And they're designed to facilitate discussion amongst groups of older people about what is important to them as they get older. And each guide is divided into 3 sections. First, about planning for everyday life in your older age. So that covers topics like accommodation, services, leisure, spirituality, social activities. Part 2 is about your finances. And then part 3 is about planning for your end-of-life healthcare. And each section takes you through a series of questions on these topics to get you thinking about what's important to you as you get older, what you want your life to look like, and who understands the importance of this to you and could support you to make decisions on your behalf on these things. And so at the end of the sessions that we ran, we'd provide some education about future planning documents and make some suggestions about culturally appropriate services that people could access to help put those documents in place when they're ready. So we've rolled out these guides in a number of conversations with groups of older people, and so far our experience of them has been that they're really a really useful resource to have very rich, rewarding and quite powerful conversations, which do help to clarify for people what they want as they get older, and maybe get some thinking and gives them a bit of confidence to then go and have further conversations with those trusted family members and friends who can support them to have the older age that they want to have. So we're really excited about these resources we've created, and happily we have secured some more funding from Perpetual to continue this work. We've recently recruited a lawyer to roll out the next phase of this project. We're not 100% sure what the next phase is going to look like yet, but watch this space. The second project I'm going to talk about is the Murrumbidgee Tele Law project that I mentioned earlier. So that came about as a result of our partnership with St Vincent's Health Network in Sydney. Through our partnership with St Vincent's, we became aware that St Vincent's had a particular relationship with the Murrumbidgee Local Health District. So they would, for example, provide them with specialist health services and coaching and training, etc. And that they use telehealth infrastructure to deliver health services to that region. And so we started to wonder if perhaps we could leverage that existing digital infrastructure and the relationships that they had with health professionals in that region and adapt this for legal services. And we're also interested in the region because of the high proportion of older people and the fact that there's very few legal services in that region to respond to the legal needs of that population. So we managed to secure some funding from the Attorney General's Department for a pilot project, which commenced in late 2019. And it got off to a great start. Murrumbidgee were really really receptive and enthusiastic about the project. We established some really good relationships. We designed a remote service delivery model incorporating, we called our tele-law facilities. We set up referral processes, we co-designed some education, and we got some promotional resources up and ready to go. And we were just about to launch it. And the launch was going to involve an education roadshow. So we were planning on heading out in person into the Murrumbidgee because we're really trying, I suppose, to bring across our learnings from our experience in health justice partnerships about the importance of relationships to models like this. So we wanted to start the initiative with an in-person roadshow where we got that opportunity to meet people, sit down with them, deliver education in person, but also have those incidental conversations that might cement some important relationships to get things going. Then, of course, what happened? COVID happened. So the education roadshow sadly never happened. We pivoted. We then delivered all of the education that we'd planned online instead. And look, we still got some great feedback. There was a real appetite in the region, and we did start to develop some relationships with key workers. We got some secondary consultations coming through, some referrals coming through, but unfortunately, as momentum was just starting to grow, our funding ran out and we didn't have any capacity to resource the project from the end of 2020. In June 2021, we managed to secure a discrete one-off grant from the Attorney General's Department to continue the project. Because it was just a one-off grant, though, we didn't seem to be much point trying to sort of revive the referral pathway. So we made the focus of that grant on education, and we delivered some in-person and online education to health workers and community members in the Murrumbidgee Local Health District earlier this year. Including use of our conversation guides, which again were really well received in Murrumbidgee. conclusion is that we haven't given up on it. We really did identify a need in that region. And as I said, a real appetite for legal services there. And if funding permits, we really would love to have a go. There is another go. There's so much need in regional and rural Australia. And we feel like there is a place for a model like this. It's sort of an adapted version of a health justice partnership. So we partner with health services or other services that older people use. And then we manage to find the sweet spot of incorporating enough kind of in-person engagement at the start to build those and cement those relationships, but then that also utilises digital infrastructure to deliver the bulk of the services to kind of overcome that tyranny of distance that we face in Australia. So I guess the lesson that we've learnt about this is patience is required for something like this. It is probably something that's going to take several years to really establish. And so we're on the lookout for some multi-year funding to have another crack at it. Another interesting project we ran recently was developing some easy read resources. So we were looking at developing some more self-help resources for our seniors law program. We got one of our pro bono partner firms to undertake a gap analysis about existing self-help resources out there for older people. And what that identified, it was that there wasn't a lot in the way of easy read resources. And for a topic like powers of attorney, we felt that this was actually a really important gap, as it's quite likely that there are people out there who could benefit from learning about this topic that might have some accessibility issues, meaning they can't read a standard fact sheet, whether that's due to lack of English or a physical or a cognitive disability. So we worked with a group called the Information Access Group and some community groups that we were connected with through St Vincent's to co-design an easy read guide to powers of attorney in New South Wales. And you can see there that's kind of the format, that it's really simplified, simple text coupled with graphics to improve accessibility. Yeah, and so that resource is now available on our website. Randomly, it's also been translated into Russian. As people working in the community sector would know, I think sometimes you do need to be a bit opportunistic about funding opportunities. And Waverley Council in Sydney's East learnt about our English self-help easy read guide and was really interested. But they have a high proportion of Russian older people in their local government area, and yeah, found some funding for us to translate that into Russian. So there you go, an English and a Russian easy read guide. Both resources available on our website if people are interested. I'm really happy to send that link around after this session. And I should mention, we also have some posters that I can happily give to people. They have a QR code on them, so you just need to scan the QR code and it automatically sort of connects you to the resource on your phone or your iPad. So if anyone's interested in getting some posters, let me know. But I should emphasise it's about powers of attorney specifically in New South Wales, both of those resources. And finally, the last project I'm going to talk about is the elder abuse screening tool. That's another project that we conducted in conjunction with St Vincent's in Sydney and also with NARI, the National Ageing Research Institute. So in 2018, after identifying that there were no validated elder abuse screening tools, or specifically for elder abuse, available for use in Australia across diverse health settings, NARI developed the Australian Elder Abuse Screening Instrument, or the Aussie tool, and they piloted it at St Vincent's in Melbourne with social workers. It had limited success, unfortunately, as it did target social workers who reported they were already confident detecting elder abuse, and they suggested the tool might be more suitable for use by frontline staff. So with NARI's endorsement, we secured funding in 2020 for a pilot to adapt the Aussie tool using a co-design process for nurses working on the acute geriatric ward at St Vincent's Hospital in Sydney. So we established a steering committee for the project, including representatives from NARI, other service providers, and a consumer representative. And then we worked closely with nurses and other health workers at St Vincent's to adapt that original tool for use on the geriatric ward. The process involved, first of all, the ethics approval process, which was very, I don't know if anyone else has ever done that, but it was very involved and drawn out. Then there was the actual design phase where we co-designed the tool with the nurses. Then there was training of the nurses to use the tool, and then finally implementation and evaluation. And the pilot actually only just concluded in September. And there you can see the tool there, the traffic light system. So if concerns, it's only if concerns are identified in the green section that you move on to the yellow section, which is on the next page. And then you only move on to the red section, obviously, if concerns are identified at the yellow. And if you do reach the red section, it automatically triggers a referral to social work. So naturally, this project was also heavily impacted by COVID. We were meant to have a much longer implementation period on the ward. I think we only ended up having 3 months for the implementation period. Of course, all of health, but particularly nurses have been very, very stretched due to COVID. A lot of them were often off sick, turnover of staff. There was a high proportion of agency staff that were used at the time, meaning that they hadn't been trained to use the tool. And of course, then there were just several lockdowns throughout the course of the pilot due to COVID outbreaks on the ward. So it was a difficult context in which to roll out a project of this type. Our findings in that sort of shortened implementation period were that while it didn't prompt an increase in referrals to the lawyer at St Vincent's Hospital in that period at least, there was definitely an increased uptake of tool by nurses throughout the course of the pilot, suggesting a growing confidence with it and a willingness to use it. There was also a slight increase in secondary consultations to the lawyer, suggesting a heightened awareness of elder abuse on the ward. And the nurses did report that they found the tool really useful. Actually, aside from elder abuse aside, they found it a really useful tool to establish rapport with the patient. It's actually really useful just generally in their care for the patient. In terms of our recommendations, so there are a couple of tweaks that we have suggested need to be made to the actual tool based on feedback from the nurses. But the main recommendation that we made was that the tool should perhaps next be trialled in a subacute environment rather than the acute environment for the reasons listed there on the slide, that your subacute, and that's what Carolyn was talking about earlier, that the subacute environment really does provide a greater opportunity to build rapport with patients because they're there for longer and they're often not as acutely unwell. It's a less pressured environment, so you've got more time to sit with patients and have a conversation. And then there's less risk that the screening doesn't get done at all when you don't have to wait for the acute pain and delirium to resolve. So it was a really interesting project. And in some exciting news, NARI actually only just announced that they've, a few weeks ago, secured some really significant funding for the next phase of this project. So they are going to be rolling out use of the screening tool in 10 subacute hospitals around Australia. So yeah, we're really excited that we got an opportunity to be part of that, and we're looking forward to seeing what the next phase of the project is going to look like. So yes, that brings me to the end of my presentation about our project work and our work generally. I'm very happy to answer any more questions that people have in the remaining time that we have.
We do have a couple more questions that so the first one goes back to the case study, and it's interesting that you've actually got 3 parties there. You've got the nursing home as well. Do trilateral relationships in these elder abuse cases make it more complex to resolve these issues?
I was a little bit unsure about that question because there actually wasn't a nursing home involved in Evelyn's case. It was the granddaughter was trying to send the Evelyn to a nursing home, but she wasn't actually in a nursing home. And
Okay.
I wasn't really sure about that question.
Great. Okay. And also a question regarding the caseworker sort of role that you're taking on with this program. In Tasmania, there's a program that's located within the Legal Aid Commission Tasmania, and services are liaising across state boundaries about what is working well in relation to effective advocacy. And I might just put in a bit of a response to that one. I mean, that's one of the really important roles that EAAA has, is bringing people that are working in the elder abuse space to facilitate and share learnings. And I know that that is an important role that we have at EAAA. But would either of you like to comment on about the opportunities to share what's working well with other people that have been involved in some of the trial sites around the country? Yvonne, did you have any?
Oh, sorry. Sorry, I'd unmuted myself and then muted.
Oh, that's okay, Carolyn.
So we have meetings regularly with other organisations that are funded under the same funding that we receive, and they are across state lines. Mm-hmm. And we also have a Health Justice Partnership Community Legal Centre meeting. So that is just New South Wales. So there is communication. It would be good, I think, to have more communication nationally. And it's
a good, the conferences are a great opportunity to be able to do that as well.
Yeah, they are. Yeah. So
now I am conscious of time. We do have a very brief survey that we would like participants to do, if they could, before we finish up. So could we get that poll happening now, please? And if you are not already, I would ask you to consider to become a member of EAAA. We are working hard in this space to end elder abuse as part of a national voice, and your support is very important to us as well. So I'd like to take this opportunity to sincerely thank Yvonne and Carolyn for sharing their work in the health justice from Justice Connect. I think it's a really important program, and it's good to see that you can provide a safe environment for people that feel more comfortable to be able to discuss their concerns. And it really highlights that these cases are very complex, and sometimes we need to think in different ways about providing those safe environments. So thank you, Yvonne and Carolyn. And thank you for joining us all. And we're right on 1 o'clock. So thank you, everyone, for attending today. Goodbye.